Yeah, let me introduce
Okay.
Professor Dr. Muthukumaran Vellaichami from India. He's a emergency medical professor in Stanford University, Children's Mercy Hospital Clinics, specialization in any emergency medications. Previously, he has delivered a lot of emergency medical topics. He has covered a lot of medical topics in special medicine department, Government Siddha Medical College. Now, today he's going to deliver syncope in pediatrics, syncope in children. Welcome, Professor Dr. Muthukumaran Vellaichami.
Thank you so much,
Yes.
sir. Appreciate it. And thank you everyone for coming to this seminar on syncope in children. Uh, so we are going to talk about syncope in children. What is syncope and what is pre-syncope? Syncope is abrupt loss of consciousness and postural tone resulting from transient global cerebral hypoperfusion followed by spontaneous complete recovery. Pre-syncope, on the other hand, feeling one is about to pass out. They have not passed out yet, but remain conscious with a transient loss of postural tone. Syncope often results from falling systolic blood pressure below 70 or MAP of 30 to 40 millimeter of mercury. Syncopal event is typically preceded by prodrome lasting from several seconds to 1 to 2 minutes, characterized by nausea, epigastric discomfort, blurred or tunnel vision, muffled hearing, dizziness, lightheadedness, diaphoresis, hyperventilation, palpitation, pallor, cold and clammy skin, or weakness. Most cases are benign, but an evaluation must exclude a rare, life-threatening cardiac or non-cardiac disorder. We are going to go very briefly into those possibilities. It affects 15 to 25% of the children and adolescents. It peaks between 15 and 19 years. There is a female predominance. Before the age of 6, if that happens, one should rule out seizures, breath-holding spells, and cardiac arrhythmias. I would say even less than 10, one should rule out other underlying causes. Outside that age group, non-cardiogenic syncope or vasovagal syncope or vasodepressor syncope is the most frequent cause of pediatric syncope, 61 to 80%. The recurrent rates of syncope ranges from 33 to 51% when they are followed up for 5 years. So the recurrence rate is also there. So you need to give anticipatory guidelines or guidance to the parents. There are 3 major causes or 3 major categories of pediatric syncope. One is neurally mediated syncope, second cardiovascular mediated syncope, and non-cardiovascular type. These are the differential diagnoses of pediatric syncope. Cardiovascular mediated syncope, it is less common, which is 4%, but when it happens, it can be life-endangering. Neurocardiogenic, so-called vasovagal, which is the most common syncope, especially in adolescent girls. I could say vast majority of them are vasovagal. Then one should remember orthostatic hypotension, POTS or postural orthostatic tachycardia syndrome, convulsive syncope, reflex syncope, psychogenic syncope, other situational syncopes with coughing, sneezing, micturition, drug and toxin induced, and sometimes syncope can be caused by hypoglycemia and other electrolyte abnormalities. Neurocardiogenic, the most common vasovagal. This is a benign syncope. Postural changes causes syncope here, like prolonged standing or sitting, or exposure to obnoxious stimuli like anger, pain, sight of blood, and often there is a positive family history. The cardiovascular mediated syncope is the one causes higher mortality and higher incidence of sudden death. So it's very important to rule out the cardiac causes of syncope. The cardiac causes could be three kinds, could be arrhythmias, structural heart defects, or cardiac tumors. The arrhythmias can be complete heart block, sick sinus, tachyarrhythmias like SVTs, SVTs, and ventricular tachycardia, or ion channelopathies like long QT interval syndrome or Brugada syndrome. The cardiac causes, structural ones, are valvular aortic stenosis, hypertrophic obstructive cardiomyopathy, coronary artery anomalies, primary pulmonary hypertension, Eisenmenger syndrome, mitral valve prolapse, neuromuscular disorders. These are the red flags one should focus on when you are evaluating syncope. In any patients, this needs to be done. I have seen patients with pre-excitation syndrome in an adolescent boy. And definitely in children less than 10 years, you need to focus and make sure they don't have underlying cardiac or other illness that can cause sudden cardiac death. Like history of heart murmur, acute attacks associated with the hypertonic or cyanosis, syncope during exercise, including swimming with exertion, family history of early sudden death, long QT interval syndrome, sensory neural hearing loss, familial heart disease, medication that can result in long QT syndrome, arrhythmias, absence of usual premonitory symptoms or precipitating factors associated with neurally mediated syncope. Unusual syncope triggers such as loud noises, fright, and extreme emotional stress. So if you have any of those, these patients needs to be further evaluated by cardiologist. This is a systematic review published in 2020. I want to show you some interesting. There were 500 articles were scanned, then the 11 fulfilled the criteria. These are all the 11. If you really look at it, the most common being vasovagal, in some there was most common being POTS and the tilt induced. It's very important to know it is a retrospective study, so most of the diagnoses they were made like 10 or 20 years before that time. They didn't do thorough evaluation. For example, the Zhang had a 260 patient tilt induced. That means that particular group, they did the tilt testing for all those patients while others they did not. Based on the systematic review, which about 3,700 patients, the top 10 or the one that cut more than 1% or vasovagal being predominant 50%. Other important point is unknown category still plays a significant role. That means there is 20% of the patients never had a diagnosis. Others, you need to be familiar with POTS, cardiac, neurologic, breath holding spells, tilt-induced, psychiatric, and orthostatic hypotension. Among cardiac etiologies, again, the vast majority of them are unspecified. That really kind of bothers me. And anyway, one should look for arrhythmias, mechanical obstruction, reflex, long QT interval syndrome, sinus node dysfunction, third-degree AV block. But any patients is suspicious of cardiac cause, please refer them to cardiologists to have a thorough cardiac evaluations, especially if you are dealing with children less than 6 years or less than 10 years. The neurological causes would be unspecified again. The vast majority of them are, but epilepsy can cause or present as syncope, atypical seizures and pseudo seizures. Psychiatric etiologies, hysteria, conversion, depression, anxiety, adjustment disorders. This one I bring in, I wanted to show you important points. It's this just published in Pete's Neuro 2025. So in a functional syncope, that means the syncope they at least diagnosed to have no organic etiology. When they evaluated these patients, these are all the findings they found that really threw me off. What are those? Here you go. Yeah, here you go. Look at that. The results of diagnostic testing on those patients were 35% of them had low iron stores. 19% of them had anemia. 83% had hypovitaminosis. That means it's not vitamin deficiency, but the low vitamin level. And 14% had abnormal EEG and EKG 8%. Holter monitor found premature integral contraction 14%, so on and so forth. So that makes me wonder, even the so-called functional syncope have underlying issues. I think most of the kids needs to at least to get the labs done, which we are going to talk about, like vitamin D, iron levels, EEG and EKG. I do not know about EEG. Not everybody agrees. In my opinion, EKG needs to be done in all the patients. There is a concept called vasovagal syncope. We just told vasovagal syncope is a benign condition which is more common. There is a variant in vasovagal syncope is called malignant vasovagal syncope that can cause sudden cardiac death. So what is the diagnostic criteria for malignant vasovagal syncope? In most patients, there is a predisposing factors, history of syncope, and the positive hemodynamic response during HUT, meaning head up and tilt test or tilt table test, and other causes should be excluded. In these patients, the asystole lasts more than 3 seconds. That means all those patients need to get HUT in order to make the diagnosis of malignant vasovagal syncope. The malignant vasovagal syncope is an extreme form of vasovagal syncope. It's like any other syncope. They will have insufficient blood volume, excessive vasodilation, and abnormal norepinephrine metabolism. In order to make the diagnosis, you got to have a history of syncope and head up tilt test, and that we should exclude other causes of loss of consciousness. And these patients may need health education, pharmacological intervention, cardiac patients, sometimes cardio-neuroablation. So what is the incidence of malignant vasovagal syncope? Actually, only there are 10 papers have been published on this particular title. So the estimated incidence is 3.5 to 4.5%. The most common complaints are gastrointestinal, nausea, stomach pain, and vomiting. And this paper reports there is a good response to medical therapy using beta-adrenergic blockers, alpha-adrenergic agonists, fluorocortisone, vagolytic medication, with only one patient requiring cardiac pacemaker. Let's talk about postural orthostatic tachycardia syndrome. Orthostatic intolerance is defined as the symptoms and signs of presumed cerebral hypoperfusion or sympathetic activation while standing that are relieved by recumbents. POTS in adults consists of chronic orthostatic intolerance and sustained increment in heart rate more than 30 beats per minute or absolute heart rate more than 120 beats per minute, or both, within 10 minutes of active standing or head up tilt test. How to evaluate? Look for triggers: prescription, non-prescription drugs, nutrition and fluid intake, menstrual history in adolescent girls and females, psychosocial stressors, school history, special attention to orthostatic intolerance, and documents how severe it is and what are the aggravating factors are. These are all the symptoms of POTS. Orthostatic symptoms like dizziness, lightheadedness, near faint, blurred vision, blackout or white out of vision, weakness in legs, poor concentration, headache, nausea, sympathetic overactivation like palpitations, chest pain, migraine, tremulousness, anxiety, pallor, and excessive sweating. This particular information came from Texas Children's Hospital, where the adolescents had these kind of somatic symptoms because of POTS, like chronic fatigue, nausea, sleep disorder, sweating disorder, migraine, cognitive dysfunction, abdominal pain, chronic daily headache, vomiting, weight loss. It tells you when you have a non-specific symptoms like that, maybe they are having POTS, postural orthostatic tachycardia syndrome. They need to be evaluated for it. There are four phenotypes in the POTS. One is hyperadrenergic POTS, where there is increased sympathetic activation resulting in palpitations, fast heart rate, chest pain, tremulousness, migraine-like headaches, anxiety, and sweaty extremities. Like an increment of more than 10 millimeters of systolic blood pressure within 10 minutes of standing up or tilt, or orthostatic plasma norepinephrine if it can be measurable more than 600 picogram per ml. Autonomic sympathetic storms may occur in this subset of patients with extreme rise in BP, anxiety, headache, and other features of sympathetic activation. The potential causes for hyperadrenergic POTS: norepinephrine transporter deficiency, pheochromocytoma, mast cell activation disorders, and baroreflex failure. Second group is hypovolemic and deconditioned POTS. 30% had hypovolemia, venous pooling in the legs, and mesenteric bed during standing up or tilt, result in modest increments in heart rate or increase in cardiac output. Orthostatic intolerance syndromes such as POTS, NMS are very common in children and adolescents. Sometimes the presenting features will be just chronic fatigue. Young adult females with POTS and chronic fatigue syndrome have higher markers of sympathetic activation. They have a high prevalence of low iron stores and the low vitamin D. So all those patients need to be checked for iron status and the vitamin D levels. This category is called neuropathic POTS. These patients have partial distal autonomic neuropathy caused by autoimmunity. It develops over weeks or days and involves orthostatic hypotension, GA dysfunction, Zika complex, bladder retention, and anhidrosis. This autoimmune disorder may be associated with cancer in adults, so be careful. When you come across these patients, they need to be evaluated for underlying cancer. Other group is called POTS with joint hypermobility, especially Marfan's and Ehlers-Danlos syndrome, that kind of patients. So physical examination, excessive postural tachycardia, when you stand up, the heart rate goes up, or tilt table test. The lab studies warranted in these patients are complete blood count, serum ferritin, CRP, electrolytes, VN, creatinine, glucose, 25-hydroxy vitamin D, TSH and free T4, and plasma metanephrine if it is available. Neuroimaging is rarely useful in these patients. Most of the time, the blood test is more important, plus head-up tilt test. So in patients with syncope, detailed history, time of the day, time of the last meal, activities leading up to the event. And one should elucidate associated symptoms like lightheadedness, dizziness, palpitation, chest pain, headache, shortness of breath, nausea, pallor, diaphoresis, visual changes, and auditory changes. Environmental factors: upright posture, prolonged standing, change in posture, crowding, heat, fatigue, hunger, or concurrent illness. Loss of consciousness is usually brief, lasting from few seconds to 1 to 2 minutes, followed by rapid, spontaneous recovery without neurologic deficits. During the episode, tonic posturing or brief clonic seizures, and it's rarely associated with urinary incontinence. Always elicit Christian and past medical history, family history, and history of congenital heart disease, metabolic disease, medication usage, and pregnancy and psychiatric history. Pseudosyncope and pseudoseizures are common among females, especially young females and adolescents. Hyperventilation and conversion syncope commonly occurred in adolescents, usually in high emotional setting. It's rare in children less than 10 years. In true syncope, consciousness returns in 1 minute sometimes, and consciousness can persist up to 5 minutes, but that is very rare. often associated with other orthostatic vital signs, neurocutaneous lesions, and features associated with cardiac disease like dysmorphic facial features, morphons, and Ehlers-Danlos phenotype, and deafness. So all these patients needs to have EKG, especially with exercise and the recurrent in children less than 10 years. The cardiology referral need to be done if you suspect or if you have any red flags. They automatically do EKG, echo, and Holter monitoring. EEG when you suspect seizures. Neuroimaging studies not routinely recommended. Autonomic function test if you suspect autonomic failure or autonomic dysfunction by tilt table and quantitative pseudomotor oxygen reflex test. So this one we looked through tilt table testing. So what are the indication for head up tilt test? If you wanted to have an extensive knowledge in this particular topic, actually in 2025, Indian Heart Journal has a beautiful review on head up and tilt test. So indications are single syncopal episode in a high risk setting that might cause physical injury, or multiple episodes in the absence of structural cardiac disease, or patient with structural cardiac disease when cardiac syncope is considered unlikely. Recurrent unexplained falls, susceptibility to reflex syncope, discrimination between orthostatic hypotension and reflex syncope, carotid sinus syndrome or carotid sinus hypersensitivity, differentiate syncope from epilepsy, especially when abnormal movements occur during loss of consciousness, frequent syncope, many times per day or per week, suggesting psychogenic pseudosyncope. So how to do the head up tilt test? The patient should be upright at an angle of 60 to 80 for 50 to 60 minutes on tilt table with a supporting footboard. There are two recommendations, one by ACC and AHA, American College of Cardiology and American Heart Association. Another one is ESC, European Society of Cardiology. They have a little bit different tilt table test. If you read this article in 2025 Indian Heart Journal, they prefer ESC guidelines than American guidelines. The tilt table test results is positive when the symptoms of syncope or presyncope are reproduced. The tilt table test can be done in children as young as 3 years. And even with all those testing, still 40% of the patients have recurrent syncope do not receive a specific diagnosis. This is from the Indian Heart Journal, just published this year, and they have a specific way to make the diagnosis of vasovagal syncope without asystole, with asystole, orthostatic hypertension, POTS, so on and so forth. There are specific parameters tells you change the BP and change the heart rate. So when you are interested, please go through, otherwise it is too exhaustive for this talk. So diagnostic evaluation of ped syncope, complete blood count, serum iron, TABC, ferritin. I always do CRP just to make sure the ferritin is not raised because of inflammation, CMP, and cardiac EKG, echo, and Holter. Autonomic evaluations. Not all the patients need to get it done, but those if you suspect tilt table testing and pseudomotor axon reflex test, thermoregulatory sweat test. Sometimes you need to check urine specific gravity and urine sodium levels, and pregnancy test in menstruating females. When the patient comes to emergency department with these symptoms of syncope, look for red flags and consult cardiology. They will get the EKG, echo, and Holter monitoring. Or during the routine examination, if the EKG is abnormal, again, we put them into cardiac category. If the patient is positive for pregnancy, and of course you need to make sure it's a normal pregnancy, ectopic, or ectopic with cardiac disease. If there is seizure suspected, of course, we need to get the neurology consultation, EEG and MRI. the vasovagal is suspected, increased fluid and salt intake, compression stockings, reassurance, no further testing. This is the most common type. But there is other causes of syncope suspected. For example, pseudo-seizures, pseudo-syncope, consult psychology and psychiatry. We suspect POTS, tilt table test, and the pseudomotor autonomic test. And these patient vasovagal syncope need to be followed up with PCP if there are recurrent symptoms. If there are recurrent symptoms, you need to consult cardiology and neurology. The mainstay of treatment for vasovagal syncope is educating and counseling the patient, if it is adolescent, the patient and parents. Neurocardiogenic syncope almost always resolves within months to the max of 5 years. The parents are encouraged to maintain adequate hydration and enhance dietary salt intake. Patients should learn to recognize and avoid triggers and situations inducing syncope. So, non-pharmacological treatment for vasovagal syncope. Education, counseling, reassurance, especially for vasovagal syncope. Avoid precipitating triggering factors for those people standing long or without having a food. Those needs to be avoided if you find that is a triggering factor. Increase water and salt intake. 1.5 to 2.5 liter of water daily. This is adults. At least 2.2 to 5 gram of salt daily. Isometric counter pressure measures like leg crossing, buttock tensing, squatting that improves the blood flow back to the heart. Head up sleeping, abdominal binders, thigh high or below knee elastic compression stockings, and psychological counseling, especially when you are dealing with pseudo-syncope or pseudo-seizures. If despite these conservative measures, the syncopal episodes become refractory, then one need to give pharmacologic therapy. There are varies. Can be beta-adrenergic antagonists, as we mentioned with the dose, or alpha-adrenergic agonists, anticholinergics, and SSRI, especially when you suspect underlying psychological issues, and mineralocorticoids if you suspect underlying endocrinology. So, vast majority of patients respond to beta-adrenergic antagonists and alpha-adrenergic agonists. Other three you need to use in a selective populations. Prognosis. The neurocardiogenic syncope, or otherwise called vasovagal syncope, where there is a loss of consciousness, lasts between 5 and 20 seconds, rarely extending to minutes. The recovery phase lasts 5 to 30 minutes. Recovery can be associated with fatigue, dizziness, weakness, headaches, and nausea. Prognosis for recovery is excellent in neurocardiogenic syncope. Spontaneous recovery within the first year after the onset. 5 to 10% of symptoms can happen up to 5 years. There is a group called convulsive syncope. Occasionally brief tonic or rarely clonic or tonic-clonic or myoclonic seizure may accompany a syncopal episode. These convulsions recover rapidly and spontaneously with no post-ictal period. It's very important. Or post-neurologic sequelae. It's a result of transient cerebral ischemia and is not indicative of an epileptic predisposition. Situational syncope. Syncope occurs in close proximity to a specific trigger like cough, defecation, micturition, diving, sneezing, trumpet playing, weightlifting, and any of Valsalva maneuvers. The common denominator is most of the triggering factors are accompanied by Valsalva maneuvers. Hyperventilation syncope. This is preceded by symptoms of paresthesias, lip tingling, and anxiety or panic attacks. Syncopal episodes secondary to cerebral vasoconstriction triggered by hypocarbia. It is common among adolescent age group and is rare in children younger than less than 10 years. Psychogenic syncopes, patients with pseudo-syncope and pseudo-seizure typically use the event to consciously or unconsciously avoid an unpleasant emotional situation. The most important cause of syncope in pediatric patients, especially young female, is psychogenic syncope. The unique features of psychogenic syncope are as follows. Episodes are extremely frequent, meaning sometimes you can have several episodes in a day. The episodes are usually not associated with injury or lack any of the usual precipitating or triggering factors. The patient experiences onset of syncope in the supine posture. Even when they are supine, they will have syncopal episodes. Patient fail to regain consciousness rapidly after syncopal episode. It's an important thing. They will kind of remain unconscious for longer hours because it is psychogenic or pseudo. During which time there are no cardiovascular neurologic abnormalities if you are monitoring those. And the assumption of when you fall down, they do not get better. The others do get better. These patients show remarkable indifference to their syncope. During tilt table testing, these patients suddenly faint, but there is no change in the heart rate or blood pressure. So this patient needs to be evaluated thoroughly for psychosocial issues. If they have a conversion reactions, most commonly associated with sexual abuse. So you do not dismiss them as a behavioral issue. There is an underlying psychological stressor the patients undergo, the way they show or express as pseudo seizures or pseudo syncope. So do not just dismiss them. It is a behavioral or moral issue. Clinical cues for psychogenic syncope. Eyes are usually tightly closed most of the time with the lid flutter. Many of these patients have syncopal episodes during tilt testing, but with no change in the heart rate and blood pressure. In conclusion, syncope is a common presenting problem with wide differential diagnosis. The most cases of syncope are benign, which is vasovagal. Rarely, it may be the first warning sign of underlying cardiac or non-cardiac disease. Because it happens in adolescents, do not dismiss them. Always get an EKG. It may be a pre-excitation syndromes not identified earlier. From cardiac evaluation, especially when there is a family history of sudden cardiac death, familial heart disease, known or suspected heart disease, exercise-induced syncope, syncope triggered by loud noises, fright, and extreme emotional stress, or an abnormal EKG. This concludes the seminar on pediatric syncope. I will open the floor for any questions. Thank you. I have given 3 links. One, all these, including this one, will be recorded and uploaded into the YouTube. And the second one is the medical news for public. And another one is medical news for public in English, one in Tamil. So if you like it, follow and share with your family, friends, and whoever you know.
Sir, how can we differentiate fainting due to cardiac and non-cardiac causes, sir?
Oh, number one, if there is a slide. Oh, let me kind of pull that one up. I'll show it here. There is a slide of red flags. This is the only thing you need to know. Oops. Yeah, here you go. Not that area. Do you see it? Can you able to see it? Are you there? Anyway, so these are all the red flags. When you have any of those, history of heart murmur, acute attacks associated with hyperpnea cyanosis, syncope during exercise, family history of sudden death, medication that can result in long QT interval syndrome. So all these patients need to have an EKG and look for QT interval and pre-excitation markers and absence of usual premonitory symptoms. And also very important, unusual syncope triggers such as loud noises, fright, and extreme emotional stress. So these patients needs to have automatically cardiac evaluation. There is one group. And another group, any patients less than 10 years, I will automatically get the cardiac evaluation done. That means you need to get the EKG, echo, and possibly Holter monitoring. Did I answer the question?
Yes, sir.
Okay, thank you. Next, please.
Sir, what are the warning signs in a child with syncope?
What are the warning signs? Yeah. Da-da-da. These are all. There is syncope is loss of consciousness. Oftentimes they will have nausea, epigastric discomfort, blurred or tunnel vision, muffled hearing, dizziness, lightheadedness. That usually happens. But you cannot identify them at that juncture. You can only elicit the history. The reason they come to you because they fainted. So there is no way you will know that from the story they had it before the patient fell down and then they get awakened. And once they have multiple episodes, then you need to tell them what are the things they need to avoid. They need to have enough water, enough salt, so on and so forth, without any medication. But if it becomes reoccurs, at that point, you need to get the cardiac and neuro evaluation done, and they may need to be on some medications. But vast majority of them are avoiding triggers, proper fluid, and salt intake that takes care of it.
Okay, sir. Thank you.
Thank you.